Welcome. Today we are covering anaphylaxis and angioedema, two conditions that can close an airway in minutes. We will follow one patient from the moment he gets sick. Along the way, we will build the mechanism from the ground up. Then we will work through the diagnostic criteria and the treatment. At the end, we will meet a second patient whose swelling looks similar but behaves very differently. Let us begin. Here is our patient. A 28-year-old man is at a wedding reception. 15 minutes after the appetizers, he tells his wife that his throat feels tight. He is flushed. He says he feels like something is very wrong. Within another 2 minutes, he is wheezing, and he cannot finish a sentence. Someone calls 911. Keep that timeline in mind. Minutes, not hours. That speed is the single most important clue in this entire video. Here is what you will take away. First, you will recognize anaphylaxis quickly at the bedside. Second, you will understand the mechanism well enough to predict the physiology. Third, you will apply the 3 diagnostic criteria without hesitating. Fourth, you will give epinephrine correctly and know what to do when it does not work. And fifth, you will separate histamine-driven swelling from bradykinin-driven swelling, because that distinction changes the drug you reach for. Let us fill in the history. He ate a shrimp appetizer. About 10 minutes later, his palms began to itch. Then hives spread across his chest and arms. His voice became hoarse. He vomited twice. And on the way to the ambulance, he felt lightheaded and nearly fell. Notice how many organ systems are already involved. Skin, airway, gut, and now his circulation. That pattern of rapid multi-system involvement after an exposure is the shape of anaphylaxis. Now the focused history. He has asthma controlled on an inhaled steroid. That matters. Asthma is a risk factor for severe and fatal anaphylaxis. He has eaten shellfish before without trouble. That is common. Sensitization can happen silently on an earlier exposure. He takes no angiotensin-converting enzyme inhibitor. We ask because that drug causes a very different kind of swelling. And he has never been prescribed an epinephrine autoinjector. So nothing was given before arrival. On arrival, he looks unwell. His blood pressure is 82/48, heart rate 128, respiratory rate 28, and his oxygen saturation is 89% on room air. His skin is covered in hives, and his lips are swollen. You hear stridor at the neck and wheezing in both lung fields. So he has upper airway obstruction and lower airway obstruction at the same time. And he is hypotensive. This patient needs treatment before he needs a single laboratory test. So what exactly are we treating? Anaphylaxis is a severe systemic reaction with rapid onset, minutes to hours after exposure, and it is potentially life-threatening. The word systemic is doing a lot of work here. This is not a local rash. Mediators are released into the circulation and act on many organs at once. You get bronchospasm, tissue swelling, fluid shifting out of the vessels, and widespread vasodilation. Those 4 events explain nearly every sign at the bedside. How common is this? Roughly 2% of people will have anaphylaxis in their lifetime. The leading triggers are foods, medications, and insect stings. Fatal anaphylaxis is rare, but when it happens, the deaths tend to be preventable. The most consistent theme in fatality reviews is delayed epinephrine. Not the wrong drug, not the wrong dose, simply waiting too long. So the clinical significance of this topic is really about speed of recognition. Let us build the mechanism. This first exposure causes no symptoms at all. Follow the pathway. The allergen is taken up and presented to a T helper cell. That cell drives a B cell to make immunoglobulin E, or IgE. Notice where that antibody goes. It travels through the blood and parks on the surface of mast cells and basophils. The patient now walks around fully loaded. Nothing has happened yet. This silent step is called sensitization, and it explains why our patient ate shrimp safely before. Now the second exposure. Watch what happens here. The allergen binds 2 neighboring IgE molecules and bridges them together. That is called cross-linking. Cross-linking pulls the receptors together and triggers calcium influx inside the mast cell. The cell degranulates. Preformed granules dump their contents into the tissue and the bloodstream within seconds. That is why symptoms appear in minutes. The reaction is not building slowly. It is already loaded and waiting for a signal. So what actually comes out? 2 waves. The first wave is preformed and immediate. Histamine, tryptase, and heparin. The second wave is synthesized over minutes. Leukotrienes, prostaglandin D2, and platelet activating factor. The key point: histamine drives the early flushing and itching, but platelet activating factor and the leukotrienes correlate best with severity and with shock. That second wave is also why a reaction can worsen after the first few minutes. Now follow the mediators to 4 places. At the skin, they dilate vessels and leak fluid. That gives you flushing and hives. At the airway smooth muscle, they cause bronchoconstriction. That gives you wheezing. In the loose tissue of the lips and larynx, they cause edema. That gives you stridor. And in the gut, they cause smooth muscle contraction and secretion. That gives you cramping and vomiting. One mediator release, 4 very different looking problems. All at once? Finally, the circulation. And this is the part that kills. Histamine relaxes arterial or smooth muscle. Systemic vascular resistance falls. At the same time, the endothelium pulls apart and plasma leaks into the tissue. Up to 35% of the intravascular volume can shift out of the vessels. So the patient is vasodilated and volume depleted at the same time. That is distributive shock. And it tells you the treatment. You need a vasoconstrictor and you need fluid. Now let us classify. The old teaching split reactions into allergic and anaphylactoid. We have moved past that. The modern framework asks one question. Is immunoglobulin E involved or not? Immunologic anaphylaxis is IgE mediated. Non-immunologic anaphylaxis reaches the same mast cell by 3 other routes: complement activation, direct mast cell activation, and cytokine-mediated release. Here's what matters clinically. The endpoint is identical. The patient looks the same, and the treatment is the same. Start with the immunologic group. This is classic IgE-mediated disease. The common triggers are foods, insect stings, medications including non-steroidal anti-inflammatory drugs, antibiotics, and biologic agents. Then, latex and aeroallergens. Our patient fits here. Shellfish protein, previous silent sensitization, and a reaction within minutes of the second exposure. One practical note, because this route requires prior sensitization. A first ever exposure to a food rarely causes anaphylaxis. Now the non-immunologic routes. Each has a signature trigger. Complement-mediated reactions classically follow iodinated contrast. Direct mast cell activation follows vancomycin, fluoroquinolones, and opioids. Cytokine-mediated reactions follow monoclonal antibodies and chemotherapy. Here is the clinical value. These can happen on a first exposure because no sensitization is required. So if a patient reacts to contrast on day 1, that does not rule out anaphylaxis. It points you to this column. Let us walk through how this looks. The skin is involved in most cases. Flushing, itching, hives, and swelling of the lips or eyelids. Skin findings are the most common feature. But here is the trap you must remember. In roughly 10 to 20% of cases, the skin is spared entirely. Those patients present with sudden collapse, or with vomiting and wheezing, and nothing on the skin at all. So the absence of hives never rules out anaphylaxis. Now the airway. And this is where you triage severity. Listen for 2 different sounds. Stridor is a high-pitched sound at the neck. It means the larynx is swelling. That is an upper airway emergency. Wheezing is a lower airway sound. It means bronchospasm. Other clues are hoarseness, a sensation of the throat closing, and a persistent cough. Our patient has stridor and wheeze together. Any change in voice here is an early warning sign of laryngeal edema. 2 more systems. Cardiovascular findings include tachycardia, hypotension, dizziness, and in severe cases, syncope or cardiac arrest. Remember, the hypotension may be the only finding in sting and drug reactions. Gastrointestinal findings include crampy abdominal pain, nausea, vomiting, and diarrhea. Residents often dismiss the gut symptoms. Do not. In the diagnostic criteria, gastrointestinal involvement counts as an organ system, and it can be the second system that makes the diagnosis. Now the diagnosis, the single most important point. Anaphylaxis is a clinical diagnosis. There is no test that confirms it in real time. 3 criteria exist, and meeting any one of them is enough. Criterion 1 is built around skin involvement. Criterion 2 is built around multiple organ systems after a likely allergen. Criterion 3 is built around hypotension after a known allergen. Let us take them one at a time, and notice how each one requires less certainty about the trigger. Criterion 1. Acute illness involving the skin or mucosa. Think rash, flushing, or hives, plus at least one of the following 2. Either respiratory compromise, for example stridor, wheezing, or hypoxemia, or hypotension and signs of poor perfusion. Notice what is not required here. You do not need a known allergen. You do not need an identified exposure. A patient who arrives covered in hives and hypoxic meets Criterion 1 on the spot. Criterion 2. This is the one for the patient with a likely exposure. After exposure to a likely allergen, 2 or more of the following appear rapidly: skin or mucosal involvement, respiratory compromise, low blood pressure or poor perfusion, or persistent gastrointestinal symptoms. The key word is likely, not proven. This criterion exists to catch the patient with no hives. Think of the person who eats a known trigger and then vomits and becomes hypotensive. That is anaphylaxis. Criterion 3. Hypotension alone after exposure to an allergen known to affect that specific patient. One organ system, one finding, and it still counts. Think of the patient with documented bee venom allergy who is stung and drops his pressure. No hives, no wheeze, just hypotension. That is anaphylaxis, and it needs epinephrine now. The reason this criterion exists is that isolated cardiovascular collapse is a real and frequently missed presentation. Let us apply this to our patient. He has hives and lip swelling. That is skin and mucosal involvement. He has stridor, wheeze, and an oxygen saturation of 89%. That is respiratory compromise. He is also hypotensive at 82/48. So he satisfies criterion 1 twice over. Now notice something. We reached the diagnosis using only the history and the physical examination. Nothing was sent to the laboratory. And nothing needed to be. What about laboratory testing? 2 markers can support the diagnosis after the fact. Serum tryptase is considered elevated when it rises above 1.2 times the patient baseline plus 2 nanograms per milliliter. But here's the critical caveat. A normal tryptase does not rule out anaphylaxis. It is often normal in food-triggered reactions. Serum histamine peaks within 5 to 15 minutes and falls fast. So both are confirmatory at best. Never wait on either one before treating. Now treatment. And this slide is the heart of the video. Epinephrine is the only first-line drug in anaphylaxis. Everything else is an adjunct. Understand why by mapping it to the physiology we built. Alpha-1 stimulation constricts vessels and reverses the hypotension and the mucosal edema. Beta-1 stimulation supports cardiac output. Beta-2 stimulation relieves bronchospasm and further reduces mediator release. One drug reverses all 4 problems. There is no absolute contraindication. Now the dose. Give 0.5 milligrams intramuscularly. That is 0.5 milliliters of the 1 milligram per milliliter solution. Repeat every 5 to 15 minutes as needed. 2 details residents get wrong. First, the site. Give it in the mid-outer thigh, not the deltoid. Absorption is faster and more reliable there. Second, the route. Never push standard concentration epinephrine intravenously for routine anaphylaxis. That is how you cause arrhythmia and ischemia. What if he does not improve? Refractory anaphylaxis means persistent symptoms after appropriate intramuscular dosing. Now you escalate to an intravenous epinephrine infusion. Start at 0.1 micrograms per kilogram per minute and titrate to effect. This requires continuous cardiac monitoring and ideally an infusion pump. 2 things to do at the same time. Call for help early and keep giving fluid. Refractory patients are almost always still volume depleted. Airway management. Give supplemental oxygen to everyone. Add a beta-2 agonist such as albuterol for bronchospasm that persists after epinephrine. Now the hard part. If the larynx is swelling, you may need to intubate, and you should do it early. Waiting turns a difficult airway into an impossible one. Have a surgical airway ready. If you cannot pass a tube through an edematous larynx, cricothyroidotomy is the rescue. Preparation here separates a good outcome from a catastrophe. Fluid resuscitation. Give at least 1 to 2 liters of crystalloid to the hypotensive patient, and expect to give more. Remember the mechanism. Up to 35% of the intravascular volume can extravasate into the tissues, so this patient is not merely vasodilated. He is genuinely empty. Lay the patient flat and elevate the legs if he can tolerate it. Sitting a hypotensive anaphylaxis patient upright has been associated with sudden death. Keep him supine. Now the adjuncts. And this is where expectations need correcting. Antihistamines relieve hives and itching. That is all they do. They have no effect on the airway, and no effect on hemodynamics. A histamine 1 blocker, such as diphenhydramine 50 milligrams intravenously or intramuscularly, is reasonable for symptom relief. A histamine 2 blocker adds modest additional relief. But if you give diphenhydramine instead of epinephrine, you are treating the wrong problem. Corticosteroids? Methylprednisolone at 1 to 2 milligrams per kilogram per day for 1 to 2 days is used for patients who do not respond to epinephrine. But understand the limits of the evidence. Steroids have a slow onset. They do nothing in the first hour. And current practice parameter guidance is clear that steroids are not a reliable way to prevent a biphasic reaction. So do not give a dose of steroid and feel reassured. Observation is what protects the patient. 1 pharmacology pitfall. Avoid unopposed alpha-adrenergic vasopressors in anaphylaxis. A pure vasoconstrictor raises the blood pressure number, but it does nothing for the bronchospasm. And it does nothing to stop further mediator release. Epinephrine works precisely because it hits alpha and beta receptors together. So when the pressure is low in anaphylaxis, the answer is more epinephrine and more fluid, not a switch to a pure alpha agent. Now, disposition. A mild reaction limited to urticaria or mild bronchospasm can be observed for at least 6 hours. Everyone else gets admitted. What pushes a patient toward admission? Hypotension. Any airway involvement, needing more than 1 dose of epinephrine. Underlying asthma, and a reaction where the trigger is unknown. Our patient meets several of those. He had stridor. He was hypotensive. And he has asthma. So he is admitted for monitoring. Here is the reason we observe. A biphasic reaction is a return of symptoms after the initial episode has resolved, without any new exposure to the trigger. It occurs in about 23% of patients. Most happen within 8 to 10 hours, but they have been reported as late as 72 hours out. Risk is higher after a severe initial reaction, after delayed epinephrine, and when more than 1 dose was required. Warn every patient before discharge. Before anyone goes home, 4 things. First, prescribe 2 epinephrine autoinjectors and watch the patient demonstrate the technique. Second, give a written anaphylaxis action plan. Third, refer to allergy and immunology for trigger confirmation and long-term management. Fourth, counsel on strict avoidance of the identified trigger. And say this out loud. If it happens again, use the autoinjector first and call 911 second. Not the other way around. Let us collect the cannot miss points. First, no hives does not mean no anaphylaxis. Up to 1 in 5 patients have no skin findings. Second, do not wait for a tryptase level. Third, do not substitute an antihistamine or a steroid for epinephrine. Fourth, do not sit a hypotensive patient upright. Fifth, do not discharge without an autoinjector. And finally, do not underestimate a hoarse voice. It is often the first sign that the larynx is closing. Now a second patient. A 64-year-old woman wakes at 4 in the morning with a swollen lower lip and tongue. She has no hives anywhere, no itching, and no wheeze. She took no new food and no new medication. Her history includes hypertension and diabetes. On examination, her tongue is visibly enlarged and her voice sounds muffled. Her vital signs are normal. Pause here and ask yourself, what mechanism is this? And what is missing? Here is the answer. The clues are the absent findings. No hives, no itching, no hypotension. That combination points away from histamine and toward bradykinin. Now look at her medication list. She has been taking lisinopril for 6 years. This is angiotensin-converting enzyme inhibitor-induced angioedema. And notice the timeline, 6 years. This reaction can begin at any point during therapy. A long, safe interval on the drug does not exclude it. Let us separate the 2 pathways side by side. On the left, mast cell or histamine-mediated swelling. It itches. It comes with hives. It responds to antihistamines and to epinephrine. It develops over minutes. On the right, bradykinin-mediated swelling. No itching. No hives. It does not respond to antihistamines or steroids. And it builds over hours. The presence or absence of hives and itching is the fastest bedside discriminator you have. Now follow the bradykinin pathway. Factor 12 activates prekallikrein into kallikrein. Kallikrein cleaves high molecular weight kininogen and releases bradykinin. Bradykinin binds its receptor on the endothelium and makes vessels leak. Now watch the 2 breaks. C1 inhibitor blocks the top of this cascade. And angiotensin-converting enzyme degrades bradykinin at the bottom. Lose either break and bradykinin accumulates. Hereditary angioedema on one end and the ACE inhibitor on the other. How do you work this up? Send a C4 level and a C1 inhibitor level, quantitative and functional. C4 is the useful screen. It is low in almost all patients with C1 inhibitor deficiency. And a normal C4 during an attack makes that diagnosis unlikely. Send a tryptase if you suspect anaphylaxis instead. And send inflammatory markers when the picture is unclear. Distribution matters too. Face, lips, tongue, larynx, and bowel. Treatment follows the pathway. First and always, assess the airway. Intubate early if there is any risk of compromise. For allergic or histamine-mediated angioedema, give histamine 1 and histamine 2 blockers plus steroids. For angioedema from an angiotensin-converting enzyme inhibitor, stop the drug permanently. Icatibant is a bradykinin receptor antagonist used here, though trial results conflict. And for hereditary angioedema, give plasma-derived C1 inhibitor or ecallantide. Let us close the loop on our first patient. Assessment. A 28-year-old man with shellfish triggered anaphylaxis meeting criterion 1. Plan. Intramuscular epinephrine given immediately and repeated once. 2 liters of crystalloid. Supplemental oxygen and albuterol. Admission for monitoring given his stridor. Hypotension. And asthma. And at discharge, 2 autoinjectors. A written action plan. An allergy referral. Recognize fast. Treat with epinephrine. Then observe. These are the primary sources behind this lesson. The current anaphylaxis practice parameter, the World Allergy Organization and European Academy Guideline on Hereditary Angioedema, and the major trials on angioedema management. Use them when you want the underlying evidence and the grading behind each recommendation. Thanks for working through this case with me.